How's it going? I'm Nick with ACeLL.
And I'm Thomas with ACeLL.
Just talking a little bit about our Abra abdominal system that we just got here on the shelf. So it is this top system that we're looking at here, and it's for retracted midline defects. So open abdomens with loss of domain, where you're not able to get full closure. So the system that we're talking about is the Abra abdominal ACeLL device. So what it's going to do, it provides dynamic, unrelenting tension on this midline defect. So these elastomers are what goes across basically bridges across the defect, and it provides that dynamic cyclic tension on the area. So what we're doing is basically installing it with, we have our cannulator here. So when we go in for the initial application of it, it's a one-time application that we do in the OR, and then everything from that point is managed bedside. So it's nice for these type of cases where you're not popping back to the OR for washouts, debridements, where we've seen these close within less than a week. So when we're placing the Abra abdominal system, it comes with pouches that include the elastomers, includes these button tails, and then the button anchors, which basically hold the elastomers into place when they're placed on the skin. The only things that we need for this case are like an IO-band, insize drape. We have wicking dressings that we'll probably need, and then any type of adhesive skin prep, and that's all just to kind of limit the amount of moisture that's down on this area. So when we're placing it, the surgeon will take the cannulator. We'll have a visceral protector that goes over the bowel, and then there's a surgical fish, which is basically a protector that we'll put in to basically put this cannulator in, and taking it in here, and then the elastomers will go through the cannulator loop, like so, if I can get it here. Lock into place, and then pulling through these sites. So these elastomer holes will be 5 centimeters lateral of the fascial edge, and then at 3 centimeter increments starting from the inferior aspect of the defect. So they'll go up on both sides, usually about like, you'll see like 10 of these button anchors on the defect. And then the same thing to get it onto the other side. It's the same process. Putting the cannulator through. Lock it into place, and then pulling it through. And Thomas, if you want to show the button anchors, placing those.
Yep. We've got here our button anchors. It's a non-adhesive gel-like substance that's going to sit and give tension to these bands here. All you have to do, place it here, and then you're going to pull it tight and through that little canal. This side is locked in. Same thing with the other side here. All you're going to do, place this here, pull up, and through there.
The nice thing about these button anchors is they just sit, so we'll put an inside drape like an IO band across, and then the button anchors will sit right on top of it. It's not abrasive on the skin, it kind of just sits on top, and what holds it down is that tension from the elastomers and the intra-abdominal pressure on there. So, you know, compared to normal protocol, if you guys are doing wound vacs or retention sutures or like red rubbers, sometimes the retention sutures can be a little abrasive on the skin edge, where it's nice where these elastomers, when we're inserting them, we're taking full thickness bites and it's grabbing the entire fascia and bringing it together slowly. Kind of what we do after the case, we'll put these, they're called button tails. These will go on the very edge, and they lock into place, and this is adhesive that will basically just holds everything together, keeps that tension down. These are just adhesive strips that will be there. And then what we'll also do is take like a wicking dressing, like an inner dry or some type of wicking dressing that will be, it will go the full entire length of the wound on both sides. And we'll put that, we'll take little cuts and make it so it's limiting the amount of moisture that's underneath these button tails.
What if the doc wants to use a wound vac with it?
Yeah, you can use a wound vac. The wound vac will just be placed right on top. We just say don't put the occlusive dressing over top of the button anchors. I don't know if you want to zoom in. This is kind of what it's going to look like once everything's done with the wound vac slapped on top. So after the case is over, the one thing that we do in the OR too, it's called the move. Our company came up with this idea where you are getting one person on each side of the abdomen. Thomas, if you want to show it, and your thumbs are up, and each person is kind of rocking back and forth, and it's just providing that movement to try to get the defect closed. So we'll do this 3 times a day post-op, whether it's in the ICU, 3 times a day for 10 seconds, where you're just keeping that movement and slowly pushing it to the midline. As far as like post-op care, I don't know if you want to touch on anything else, or
If you want to get into that, we can do that.
yeah, it's pretty long.
Great. Thank you very much, guys.
Thank you.